Good evening. We're looking tonight at chapter 10 out of our book. We're looking at physical disabilities, like what we call orthopedic impairments, OI in Texas, health disabilities, what we call other health impairments in Texas, or OHI, and traumatic brain injuries, TBI. So we're throwing three different categories from the IDEA into tonight's webinar. These are also all covered in chapter 10 of the book. So as we jump in, we see that an orthopedic impairment is caused by a congenital anomaly. Could be the club foot, it could be the absence of some member, usually a limb. It could be caused by a disease like polio or tuberculosis. And there are other causes like cerebral palsy or amputations, or even a fracture or a burn that causes a contracture. A contracture is when the skin, because of a burn, loses its elasticity. Therefore, the skin won't move with a joint, so the joint can't move because the skin won't allow it to, and that's called a contracture. And other health impairment, what we call OHI, this is a disorder that results in limited strength, vitality, or alertness. This includes a heightened alertness to environmental stimuli, which results in limited alertness with respect to the educational environment. This is due to chronic or acute health problems. Could be asthma, it could be ADD or ADHD, diabetes, epilepsy, a heart condition, hemophilia, lead poison, leukemia, nephritis, rheumatic fever, or even Tourette syndrome or sickle cell anemia. Traumatic brain injury, you see the long definition there, especially an acquired injury to the brain that's caused by external force. And it could be an open injury or a closed injury that results in an impairment in cognition or language or memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual and motor abilities, psychosocial behavior, but physical functions, information processing, or even speech. Now, this does not apply to a brain injury that is the congenital or degenerative in nature, or a brain injury that occurs due to birth trauma. In the case of a traumatic brain injury, the student must be born with a normal brain, and then this injury occurs later. And as with all of the disability categories that we've talked about, there has to be an adverse effect on the educational performance in order for it to qualify as a disability under the IDEA. Prevalence 0.99%. So you add these all together and you get right at 1% of school-age children. So about a tenth of that for an orthopedic impairment, which would, what, in 1,000, you get almost all of it out of the OHI. So almost 1 in 100 for an other health impairment. And then 0.04, 1 out of, what is that, 2,500 for the traumatic brain injury. So pretty rare. The other health impairment makes up the majority of this category, and my guess would be that the ADHD, ADD makes up the majority of those who qualify under OHI. But let's look at some of the orthopedic impairments. Cerebral palsy is a major one. This is damage to the brain either before, during, or shortly after the birth, and it's often related to prematurity and the intrauterine development. There are 4 types. The table on 310 explains them, but we'll just talk about the spastic. It's the most common type, and it's defined as difficulty initiating voluntary movements. There's increased muscle tone with tight muscles and stiff joints, can be difficulty in walking, or the lack of the ability to walk, can be difficulty in grasping objects, writing, and oftentimes speech are affected. and that's the most common type of cerebral palsy. When we look at this, they define it further or describe it further based on what part of the body is affected. Monoplegia would be that it affects an arm or a leg. Hemiplegia would be, think of the body as a hemisphere, one side. So an arm and a leg on the same side of the body are affected. Double hemiplegia affects the arms primarily with some involvement of the legs. And you would think that double hemiplegia would be the same as quadriplegia, but the double hemiplegia, more of an effect of the arms than the legs. In diplegia is sort of the opposite of the double hemiplegia in that all the limbs are affected, but the legs, both of the legs are more problematic than the arms. Paraplegia, both legs are affected, but there's no involvement of the arms. Triplegia affects 3 of the limbs, and quadriplegia affects the function of the torso and all 4 limbs, but there's no observable difference in involvement among the limbs. Otherwise, it would fall under the double hemiplegia or the diplegia categories. There are many other associated conditions like seizures and vision problems, sometimes hearing loss, sometimes eating, feeding, and speaking problems. And somewhere between a half and a third of people with cerebral palsy experience an intellectual disability is a comorbid condition of this. However, some kids with cerebral palsy can go on to live fairly normal and productive lives. I've got a kid that not a kid anymore, but I taught him way back in his high school years, and he is an adult now. In fact, he does promotions for the group King and Country, if you've heard of them. His name's Colby, and he's a great kid, and I say kid, he's in his 40s now. Anyway, he, despite his condition, has, even though he's used a wheelchair the entire time that I've known him, he's a smart kid and has a productive life. So as a kind of a caveat in all of these disability categories, don't assume that somebody that uses a wheelchair or a walker or any other device like that, or someone who carries a OHI label, don't assume that they're limited in their intellectual ability. They may be, but don't assume that that's the case. They may very well not be as well. Spina bifida is a different congenital disorder. It results when the bones around the spinal cord don't grow close, or they do not close or they grow together. There are 3 types. The spina bifida occulta, this is the common type that we're usually used to seeing if you know someone who has spina bifida. The next kind, the meningocele, is actually repairable. They can fix the spinal cord now in this case. The maleo-meningocele spinal cord actually protrudes through the back where the nerves are exposed. And they have an example of this on page 311 in the textbook with a drawing of a baby. So you can kind of get an idea of what they're talking about. It doesn't make very much sense when we just say it, but probably should have included a picture of that in here. But there are complications that, of course, result out of that, with the spinal cord being the main highway for the nerves. Some people end up being paralyzed. Many people end up with the loss of the bowel or bladder control or incontinence of some type. Can also be a difficulty in breathing or swallowing. Can cause seizures, and up to 90% of these people with spina bifida also have hydrocephaly, which is what we used to commonly call water on the brain. It's where the liquid is the spinal fluid actually accumulates in the head. So I've worked with students over the years that actually had stents where they were placed in their head to where it would drain that excess liquid out of their brain on a cavity on a continual basis. So you may see some of these students. Some would be, depending on other needs, they may be in a resource class, but most of these kiddos would be able to be included at least part of the time in a general education classroom. Muscular dystrophy is primarily a genetic disorder. It's characterized by general and progressive weakening of the muscles. This is a continuing disintegrative disease. The most prevalent is Duchenne. The onset usually occurs during the preschool years. There can be an initial weakening in the lower leg area is usually how this is first observed. Usually by the age of 10, they're going to need a wheelchair, and by the age of 20, a respirator. And as a result of that, death often occurs in the early 20s. But you can see as a result of that, these kiddos are going to live through their school years, generally speaking, and be progressively getting worse. So do not be surprised if you end up with a student with muscular dystrophy in a school at some point. Another one is epilepsy. This is caused by electrical dysfunction in the brain. It's interesting. There's a history of what had to have been epilepsy written about in 350 BC. So, this is a disease that we have a long history of. It results in problems with consciousness, movement, and or sensation. There are two types. There's the generalized, which affects large areas simultaneously in both hemispheres of the brain. If it's a generalized tonic-clonic seizure, then this is what's called a grand mal, grand meaning large, and of course mal being bad. This is a big bad seizure. And then there's what they call an absent seizure or a petit mal, a little bad seizure. Can be those were generalized. It can be also be a partial, where it starts in one specific area of the brain and may or may not spread. And it could be a simple partial seizure or a complex partial seizure that affects psychomotor areas. Man that I'm currently teaching with, he's 40 years old, and he has had epilepsy and it's been controlled for much of his life. But in the past couple of years, he's had two very serious seizures. One of them, he ended up in the hospital. He's actually a theater teacher, and his background is music. He was a musician. He liked musical theater. He's a music director in a church, and he also works with barbershop quartet type music. He told me he was not a concert type pianist, but he could play. Like I said, he learned how to play entertainer when he was a kid and played that just by memory. But he said that it's been very interesting since his last seizure that was so bad that he ended up in the hospital for a while. He can no longer play that. He can't remember it. So his memory has been greatly affected by this big seizure that he had. He also had music, he told me that he had written that he memorized because he wrote it, and now he can't remember it, can't play it. So still a lot to be, even though this disease has been documented for close to 3,000 years now, it's still, there's a lot to learn about it. The next one we want to look at is asthma. And you think, well, how can that possibly fit in here. Well, it fits under the category of other health impairments, and it's a respiratory condition that results in breathing difficulties. It's caused by inflammation of the airways or by tightening of the muscles around the airways, and typically results from exposure to various environmental conditions. Characteristics can be wheezing, coughing, tightness in the chest. It can be treated with medication or inhalers. Uh, in my younger days, I was a pretty active athlete and ran uh, distance races and cross country and played soccer and all those different kinds of things. Uh, and at the age of 45, I experienced adult onset asthma. I used to give my kids a hard time that had asthma, and I knew feel that some kids use it as an excuse, but it is it is rather terrifying when you go to breathe and you can't breathe. An inhaler made a difference and helped, but still, it it is a it is an issue when you just don't feel like you're able to get a breath. And in most cases, um, you're getting the breath in, but just not as much as you feel like you need or you used to get. The next we're looking at is cystic fibrosis. This is a recessive genetic disorder in which mucus, which is ordinarily watery and moistens different body organs, becomes thick and sticky. This is a degenerative disorder with no known cure. Uh, for a child to end up with cystic fibrosis, both parents must be carriers of the defective gene. So if this is something that is in your family, um, as long as whoever you marry or whoever you um, become a parent with does not have does not carry this defective gene, then your child is not going to have it. Symptoms include persistent coughing, frequent episodes of pneumonia, dehydration, large appetite with no subsequent weight gain. The life expectancy has now increased. Get that. The life expectancy has now increased to 35 years of age. Um, my former father in law had a son who had cystic fibrosis. And interesting thing about it is such a childhood disease that the folks that know about it are the people who work in children's hospitals. So even when he was an adult, when he would have a flare up, an episode of this, um, he would be put in children's hospital. So he was a married man and would go to the children's hospital when he had an issue. He has since passed at about 35 years of age. So seems to be about right on. Diabetes is a disorder in which the body does not produce or does not effectively use the insulin that it does produce. Type 1 is onset during childhood. Type 2 comes on during adulthood. It can be caused by genetic predisposition and dietary factors or some combination thereof. Symptoms: hyperglycemia with high blood sugar, increased hunger, increased thirst, increased urination, blurred vision, dry mouth, dry or itchy skin, or hypoglycemia, which is low blood sugar. And this can be caused from increased hunger. The symptoms, the symptoms thereof can be increased hunger, perspiration, nervousness, sleepiness, and dizziness. Um, so it's important for diabetics to know which way they are. And certainly this is something we need to work with the students to know if they are getting high blood pressure or if they're, high blood sugar or low blood sugar. If they have low blood sugar, which is often the case, then, getting some type of sugar into them quickly, usually liquid through a juice or even a soft drink, can help stem that dizziness and nervousness. quickly. Um, I was talking to a friend the other day who was driving and felt cold and clammy and that kind of thing. And he actually has one of the meters that you can hold your cell phone to, and it will tell you your blood sugar level. So he did that and saw right quick that his blood sugar had dropped, pulled into a fast food and quickly drank a soft drink, and then proceeded to have a milkshake and then another soft drink in order to get the blood sugar up to a level where he felt okay again. So technology is great. It's helping in this area, but it's still something that we're going to have to work with our kiddos who have diabetes on. AIDS, the acquired immunodeficiency syndrome, which of course is caused by the human immunodeficiency virus. It's transmitted either sexually or through blood or from a mother to an unborn child. The symptoms here are swelling of the lymph nodes, enlargement of the liver and spleen, and a predisposition to infections, either viral or bacterial. Other problems might include cognitive, wow, can't talk today, cognitive deficits, motor functioning problems, speech and language deficits, and problems with memory and attention. There's also a susceptibility to infections that exist, and frequently the child becomes chronically ill. One of the areas that has received some attention is that by law, if you have a student who has AIDS, he carries AIDS, and you're that child's teacher, you're not allowed to know about it. The school can't tell you. If the parents choose to tell you, great, but the school can't. And that can be a little scary. And they would tell you it's not an issue. You're trained each year on bloodborne pathogens. And so if you'll follow those universal precautions, then you don't have to worry about it. And I think generally that's true, but it's still a little worrisome. So something there to keep in mind. If you do have a child who's bleeding, take those precautions. Make sure that you're keeping yourself safe. And now we'll deal with traumatic brain injury, TBI. This is an acquired head injury caused by an external force. Major causes include car accidents, falls, violent injuries, sports injuries, and all too often in urban areas, gunshots. This includes open and closed head injuries. It includes accidental and intentionally inflicted injuries, as well as self-inflicted injuries. Now, attempted suicide can cause a traumatic brain injury. Characteristics of the TBI are dependent on where the location of the injury is in the brain, whether it's the frontal, the parietal, the temporal, or the occipital lobe. They talk about different injuries that are different symptoms based on which part of the brain is affected. And sadly, we know that a lot of that research comes out of sick experiments that were done under Hitler in World War II, where they would remove parts of people's brains and then see what happened. Since then, a lot more has been learned, since we can do scans of people's brains without injuring the person. When they do receive an injury, we can tell which part of the brain is still working, which part is not working. And so we've been able to put a lot more into it. When they talk about that, many parts of psychology books don't have references. Well, because a lot of this information was found out, the research was done in very cruel ways. But that's, we've had 60, 70 years to get past that now. And a lot more research has been done. A lot more technology is involved. Also, there's a big difference in the severity of the injury and how long it's going to last. I had a student who was a beautiful girl, played soccer on a team that I coached. She was in a horrible car accident received a traumatic brain injury, but within a year, she was pretty much back to her old self, except for occasional headaches. So I got to where there was no more educational need to go along with the brain injury, and therefore she no longer qualified for special education services and was able to function fine in the general education setting without the need for specialized instruction. Other kiddos will have a traumatic brain injury and never get over it. Um, it is considered or classified as mild, moderate, severe, or very severe. And another difference is dependent on the age of the individual when the traumatic event occurs. Changes may be observed in the child's physical, cognitive, behavioral, and/or academic functioning following a TBI. To me, TBI is one of the saddest disabilities, unless it's pretty severe. And that does sound weird to say, I know, but it's real sad to me when a child has a traumatic brain injury and they remember when they were normal. They remember when they could learn just like everybody else. So they're cognizant enough to know that, and they have enough cognitive ability to remember those things, but they're frustrated because they can no longer do those things. It's really a sad situation. Um, the other thing about kids with traumatic brain injuries is there seems to be a lot of variability from day to day. One day they may pick up on a concept just fine, and you come in the next day and they don't have a clue what you're talking about. It can be so frustrating to teachers who are working with kiddos that have traumatic brain injuries. It can be very satisfying when they do make progress, but then you think you've really done something, and you come in and you got to start over. Um, so if you're a teacher and you get in a situation like that, think about the kid. He's the one living it, and then think about the parent, because every day you send that child home and they're with their parent, and that parent has to live with whatever is going on, and in many cases will have to for pretty much the rest of their lives. So that's the TBI, or the traumatic brain injury. When we look at physical and health disabilities and identifying these, in most cases, medical personnel are involved in the decision making of all eligibility determinations. So if you want a child to qualify as having another health impairment, the school will determine that there's an educational need, but someone in the medical profession will have to diagnose the ADHD or whatever the disability is that will then qualify them, and it has to meet that definition that we read on the first couple of pages. There is a wide array of disability types and different needs among these groups, and their ability to access the general education curriculum is quite varied. Their healthcare issues are paramount. So what if you learn the math timetables, but your health is shot? Need to think about accessibility of classrooms, and then what adaptive equipment or instructional technology is available that could help. And we'll talk about that a little more later on when we get down to some really practical considerations. Like right here. The instructional content for many students with orthopedic impairments, other health impairments, or traumatic brain injury will include the general curriculum, but adaptations will probably be needed. And we said, you're not going to judge this book by its cover. You're not going to look at the label and say, oh, I know everything I need to know about that kid. No, you're going to have to study what is their intellectual ability, what is their achievement levels, and understand that a lot of times there is a learning disability that is comorbid with this. There can also be an intellectual disability where they're functioning in that range that we used to call the mental retardation range. So they're going to need adaptations to the general curriculum. But in addition to that, many of these kiddos are going to need some special content to help them with their health and their physical needs, or their life skills, social skills, self-determination development, and transition skills. So I thought it'd be good for us to just take a practical look at this and kind of break these down. I know it can be a daunting task when you think about, wow, man, I could end up with a kid like this in my class. Maybe I want to, rethink my career. But you're going to find it first and foremost, like we said about all the other disability categories, first and foremost, they're kids. So let's take a look. Kids with health and physical needs. uh, for example, a student with disability with diabetes may need to learn to monitor blood sugar levels and well, should be insulin management, not insulting management. A student with an orthopedic impairment who uses a wheelchair. First of all, they need to learn how to use a wheelchair, and then as they get older and develop the upper body strength to do so, they should learn how to transfer to sitting in a chair or to transfer to a toilet for bathrooming. Um, Students may need to learn to self-catheterize. Remember, as a elementary principal, we had a young man that was, what was he, had to be about 10 years old, maybe 11, and he would come to the nurse twice a day. She would have his equipment to catheterize himself. So she would just hand him the disposable bag of his equipment, and he would go into the restroom and take care of what he needed to take care of. So that can be learned at a fairly early age, and the so that's a very practical consideration that we need to look at for our kiddos. When we get into the life skills curriculum, this is preparation for accomplishing activities and routines of everyday skills. Skills like using money, shopping, dining out, public transportation if you live in an urban area, these kinds of skills. And then, of course, this is going to vary. There are students who are never going to be able to do some of this stuff on their own. There's maybe a kid that won't be able to ever eat independently, doesn't have the muscle control or whatever to eat independently, but could still have some input in just determining food choices. Then what about job related skills? This will be appropriate for some of our students. You start with the simple, following directions, and then performing specific job tasks. And I got a couple of kiddos I want to tell you about that I worked with. We'll call one Michael and the other Mikey or Mike. Michael had a IQ of 67. He operated in what was then called the mental retardation range, and his parents decided when he came of age that he would learn to drive, which really scared me, frankly, because I watched Michael sit in his desk and pretend to drive. He always wanted to drive a school bus, he said. So he would sit there and he would have his, pretend steering wheel, and he'd reach down and change the gears and all that. And I thought, good night. What if he gets out in a car and he's thinking he's pretending to drive his desk in his classroom? It really scared me, but it has worked out. Last I heard, he was working at the Mint up North Fort Worth area. Um, his family, he still lived with his family. They lived in South Fort Worth, so he drove a significant way every day to go up there and work at the Mint. He was in part of the custodial services there, but was able to make money and contribute. Um, Another kid, Mike, um, worked with him on job skills, but he was very defiant and oppositional. We never really felt good about it because we couldn't get him to follow directions and do job tasks as he was supposed to do in school. But his parents said, well, no, he definitely needs a job. He's 17, 18 years old now, and he definitely needs a job. And he got a job at a factory up on the north side of town near where his family lived. And he had a very simple job. He was to sit there at a machine, and if a problem occurred, then he was to push the button on the machine with his hand, just push the button to stop the machine. And that was really all there was to it. He just monitored to make sure that there weren't any problems. And if there was a problem, just take his hand and push the button. Well, he determined that he could sit in a chair or in and just kind of kick back and watch everything. And so his supervisor came by and said, Mike, if you're sitting in that chair and not watching, then if something happens, it's going to mess everything up downstream from you if you don't push that button. And he said, oh, I can push the button. He said, well, how can you push the button? You can't reach it. You gotta get up and all. He said, no, I don't have to get up. And he showed him how he could reach out with his foot and push the button. And his supervisor said, no, Mike, yeah, that doesn't work. You're going to have to, you know, get up and be up here where you can push the button with your hand. He did that, for a little while, and then came back around and he's sitting down again. And sure enough, about the time the supervisor walked by, the machine messed up, and he reached up and kicked it with his foot. And the supervisor came by and said, Mike, I told you and told you, that's not acceptable. And, I think that this could have been stopped a lot quicker and a lot more easily if you were standing where you were supposed to and push the button with your finger like you were supposed to. And I'm going to write you up. And with that, Mike decided to continue to push the button with his foot by kicking it over and over again until he ended up breaking that machine. He went on to take a part that he knocked off and just pretty much destroy that part of the conveyor belt in his area. And of course, got himself fired, all because he didn't have a job related skill of just being able to follow directions. Now, the sad thing about Mike is he had an emotional disturbance, a behavior disorder, rather than any of these other disorders that we've been talking about. And in fact, that's one of the things that we see with kids with emotional behavior disorders is that they actually end up having the worst outcomes of any of the disability categories, despite the fact that they have generally are thought to have an average IQ or better. So they have one of the higher IQs of any of the disability categories, but it's not their lack of knowledge or their lack of intelligence. It's their social skills that keep them from being able to get and keep decent jobs. So sad deal there, but some of the things to think about and reasons that we are teaching job skills and following directions and those kinds of things to our students. Speaking of social skills, social adjustment could be especially important for students with traumatic brain injuries. This ability to build social relationships and develop friendships are key in establishing self-esteem. But our kids with traumatic brain injury and some of our other illnesses and injuries spend a lot of time in rehabilitation or hospitals or having medical procedures done. And all that time that they're undergoing those treatments, they're away from their school and peers. So students with physical or health disabilities may be hospitalized, or they even may have to have home-based instruction for periods of time. And during this time, they are not in the schools. So they're not able to build those relationships. Because of that, we see a lowered sense of self-efficacy due to problems learning age-appropriate skills. So all of these things need to be considered as we're working with our kiddos with the various disabilities. Self-determination skills. The basic premise here is that a student should learn to share in and make decisions, make choices, set goals for itself, and to be able to self-advocate. Students should be able to have input on selecting a career choice and can be taught to self-evaluate. For example, talking about job punctuality, and then a certain amount of autonomy, recognizing areas in need of improvement where the student starts to, as they reach adulthood and become an adult, transitioning out of high school into the real world, as we call it, then they need to be able to recognize what they are and are not able to do, and decisions be made on that basis. Um, in that transition, as we call it, there are a couple of major areas of transition planning that we talk about at this point. We talked earlier about the transition from home to school with the little bitties, but now we're talking more with our adults. This transition from school to adult living, you need to consider the living situation that this child will be able to achieve. Can they live independently on their own? Are they going to need a group home? Are they going to stay in the parents' home? Or will they need to be in some sort of institution or facility? And sometimes these decisions are very difficult. Got some friends who have a daughter who has severe intellectual disability, and they eventually made the decision to put her in a group home instead of having her live at home with them. Um, Safety becomes a big issue. Um, and so there are lots of factors that go into making these sorts of decisions. Another one that we got to look at is the transition from the hospital or the rehab setting back into the school. What are we going to have in place? Oftentimes, a portfolio for students, teachers, and parents that kind of describe what's going on and what's needed can make a major difference in helping this be a successful transition. Also, think about the physical environment. Think about a classroom. Last classroom you were in, was there room to move a wheelchair? What about a walker? What about someone who uses crutches? Was there room to maneuver those items within the classroom, between aisles and that sort of thing? What are you going to do with the kid that uses a wheelchair? You have a table for him to roll up to? Does a desk work? All of these things need to be considered. What about safety? Fire drill. What are we going to do? The first high school that I worked in didn't have an elevator. It was a two-story building, but it didn't have an elevator. Not a big deal for our kiddos that use wheelchairs if the weather was nice, but bad weather, what are you going to do? Um, Colby, the kid I was telling you about earlier, who now works for King and Country, um, on a few occasions, weather was really bad and I needed him upstairs or downstairs, and I would get some of the football players and we would carry him up or down this staircase. Um, he kind of felt like a celebrity there for a little bit, and I don't recommend it. I had a good relationship with his parents, but it's still kind of a scary thing to do. Um, but you got to think about the safety for evacuation drills, that kind of thing, and then considering scheduling, bathroom. Um, Most of these kids, or many of these kids, are going to need assistance with bathrooming, and the oftentimes the paraprofessionals who work with those sorts of things are very busy, and so that you've got to kind of go when they have the opportunity to take you. Feeding, same thing. Some of these kiddos, they can feed themselves fine, but others need help with it. And then they're out a lot for medical appointments or related services where they're getting physical therapy or orthopedic therapy, PTOT, all these sorts of things. So they can be gone from your classroom a lot, and as such, they miss a lot of learning. Think about that and trying to schedule everything. And then what technology and equipment is available. And, as much as anything, what training can you get? Real often we have so many neat things, but we don't have anybody that's trained to use them. There's equipment that's out there that many of our really low functioning, our classrooms for really low functioning kids have, that can lift the child. and they've got tracks overhead where you can lift them and move them to another area and then sit them down with a hydraulic or electric lift. Um, but if you're not trained on how to use that and how to do it safely, it's not going to do anyone any good. So always be thinking about what training you might need and be sure and request that training if you don't feel safe in what you're doing. Now, understand, most of us who teach general ed are not going to have these kiddos in our classroom if they're low functioning intellectually. Most of the time, you're going to have kids that are able to access the curriculum and be pretty self-sufficient if you're teaching general education. If you do get any of the lower functioning kids, they're probably going to come with an adult who can help them. So don't panic. Don't jump out of the profession at this point. Just be aware of some of these things and don't be afraid to ask for training that you need to feel competent and safe in what you're doing. They're kids. First and foremost, they're kids. Let's take care of them just like you would other kids, but understand that that means a different thing. So, hope this has been helpful. We've covered 3 disability categories tonight, and we will see you next week.